A lot of you are my patients, and I'm glad to see everybody. And a lot of you all know that I just recently won a dance competition, so I was going to show you a clip of the winning dance tonight, but we were having some technical difficulties. But I have a few photos to show y'all, so just hang in there. That's towards the end. Now, the point of my talk tonight is not so much to talk about surgery, although there'll be some brief surgical discussion. But I'm going to try to talk to y'all about how to stay out of my operating room, okay? Which y'all are capable of. All right, everyone in this room is. And one of the biggest things related to hips that I really want to emphasize tonight that we all need to avoid is a hip fracture, okay? Because once you have a hip fracture, it really impacts you in a negative way the rest of your life. And so we're going to talk about how to prevent that. So how are we going to prevent that? With optimizing our bone health. So I reviewed the Surgeon General's recommendations that just came out last March. And basically, he said that by 2020, half of Americans over the age of 50 will have weak bones, unless we do something about it. And there's some things that we're going to talk about how to change. So people with weak bones are obviously at higher risk for fractures, which often result, unfortunately, in the loss of mobility and our functional independence. And they can really seriously limit our activity and the quality of our life. And the thing about our bones is you can have weak bones, you don't even know it, because it's a silent disease, okay? They weaken early in life silently without any pain and without any warning, all right? Unless we do something about it, and we're going to talk about that, okay? And you're never too old to improve your bone health. I have this same discussion with my 90-year-old men and women come to clinic too, because you're never too old to impact your bone health in a positive way. Okay, so as you saw on the flyer, there's some bone diseases that they put out there that we may talk a little bit about. And I'm just going to highlight them since they put them on the flyer so y'all know what they are. There's some pretty interesting ones, but pretty uncommon. And there's some very common ones too, like osteoporosis. We're going to talk a lot about that tonight. Osteogenesis imperfecta, which we're going to just touch on because it's not very common. Paget's disease, and osteoarthritis, which is what I'm in the business of fixing. So, a brief thing about osteogenesis imperfecta. This doesn't relate probably to anyone in this room. It's a very uncommon disease. You get it at birth, and it affects your bones. All right? The reason it affects your bones is it affects how collagen is made, and collagen is one of the building blocks of our bones. Okay? So it's a disease. It's a congenital genetic defect in collagen, and it results in bad deformity, even at birth, even death in utero from weak bones. Okay, and you can see this is a picture with. I think she is about. I think she's probably 13 years old, and she has osteogenesis imperfecta. You can see the deformities of her bones. They result in curvy bones that are very fragile, easily broken. And again, it's because of weakness in the bones. But this is a genetic disease. Paget's disease is another one. Again, it's becoming increasingly rare. So this is not something that I would bet anybody in this room has. But it's a disease that is related to bone turnover. Okay, this is one that you acquire. You can get this. Okay, it's not contagious. But what happens is bone is broken down, torn apart more rapidly than it's built. Okay, and so what happens is the body tries to speed up the bone rebuilding process to try to keep up with this breakdown. Okay, so the body's feverishly trying to build bone, but it does it in a very haphazard way. The bone is very brittle, very weak. This new regenerative bone just isn't structurally strong, and bones break easily. Okay, and it can affect any bone. You can see this gentleman has a big, what we call frontal bossing or skull bossing, and that's a pagetoid bone of the skull. Okay. Now, this is the real heart of the talk. Okay, we're going to talk about osteoporosis. All right. Now, this is a disease that we all have heard about, we all know about. And it's one that probably has touched everybody in this room, if not you personally, but someone that you know. Okay? So osteoporosis is a disease characterized by low bone mass. Okay? So what happens is this picture on the left is nice, healthy, mature bone. Real thick bridges, lots of little interwoven connections, as opposed to the one on the right, which is osteoporotic bone. And what osteoporotic bone results in is very thin, fragile, less dense, less interconnected, less stout, less strong bone that can fracture under the very minimalist of forces. Okay? And so, as you can see, osteoporosis results from not having enough bone tissue, low bone density, low bone mass, as well as having weakened bone structure. Okay? So who gets it? Well, men and women get it. It's much more common in women. So 1 in 4 women over the age of 50 will get osteoporosis. Okay? 1 in 8 men over the age of 50 will also get it. So it's not just in women. Okay? It's, in men, it's often underdiagnosed. It tends to occur later in life, but men can get it too. Okay? In men, it's more likely to result from some other medical condition as opposed to how it affects women, which tends to be women who are postmenopausal without the beneficial effects of estrogen any longer. Okay? But here are the reasons that people get osteoporosis. From taking too much prednisone. That can cause weakness of your bones. From not having enough testosterone if you're a guy. That weakens your bones. From having low peak bone density. Okay, in other words, when you are growing, you don't get enough calcium, vitamin D, and nutrition in your life, and so your bone density peaks too prematurely. From prolonged immobility. Okay, from not being active, and that's one of the big things we're going to emphasize today, and from some other lifestyle things like drinking too much or smoking. Okay, so osteoporosis is called the silent thief because, well, first, there's no symptoms to tell you that you have it. All right, first symptom sometimes is when you fall and break your hip. Okay, and then it's too late. All right, so hip fractures. That's the primary discussion point tonight. So 70% of osteoporosis-related fractures are fractures of the hip. Okay? 70% of those fractures occur in women. Okay? So it's very relevant to our talk tonight. And 20 to 25% of those fractures ultimately result in death within the first year of life. Okay? So it's a serious, serious health problem. Okay? And more women die each year from osteoporotic hip fractures than from breast cancer and ovarian cancer combined. Okay, so this is a serious epidemic that we're dealing with. And to be honest with you, it's the most common thing I do every night on call is treat fractured hips. Okay, and that's a big point right there. 50% of survivors, if you're one of the lucky ones and do well with your hip fracture, 50% of survivors experience significant disability as a result of the fracture. Okay? So osteoporosis, so the loss of bone density and the structural weakness leads to bones that are brittle and can break under the slightest of strain. And this is just a little chart that tells you the frequency of different fractures of the body. And you can see the yellow line right up on top is fractures of the hip. They are far and away the most common osteoporotic fracture that we deal with and that I see every day on call. Okay? You can see in the orange, those are fractures of the wrist or the forearm. And then spine fractures are very common. That's in the green line, not nearly as common as hip fractures though. These are the osteoporotic vertebral compression fractures and sometimes results in a little bit of a humpback deformity. So let's talk about hip fractures. So this is the nuts and bolts. Okay? Most, if not all, not probably every single one, but most hip fractures result in surgery. Okay? If you break a hip, there's no way to cast it. There's no way to use crutches and get up and protect it. If you break your hip, pretty much 99 times out of 100, the only solution is surgery. Okay? And here's a picture of a pretty bad fracture involving the upper portion of the femur bone. Okay? Most of these fractures require surgery and have extensive rehab and recovery, and it just takes a long time to recover, and most of the time people just aren't the same when it happens. Most people who previously lived independently, didn't use a cane, didn't use a walker, got out and did their yard, often require some type of assistive device and require assistance at home. Okay? So this is certainly something absolutely worth trying to prevent. Okay? Here are all the ways that I and other orthopedic surgeons fix hip fractures. From the simplest, which is in the top left, to very invasive stuff. Top right, there's a partial hip replacement. Bottom right, that's a nail or a rod, which is typically what most hip fractures are fixed with nowadays. We used to fix them in the bottom left with these big plate constructs that required big, long, open incisions and was very invasive, lots of blood loss. We're now able to accomplish the same goals with minimally invasive instruments like that nail, and you can do it through 1-inch incisions on just above and below the hip, and it's much less invasive. Sounds better, sounds great. People do great, right? Unfortunately, still doesn't impact the recovery like we'd like it to. Okay? So those are all the different surgical ways we fix hips. And I left one off there. In younger folks who break their hip, and if they break it just right, they get a hip replacement, a full hip replacement, instead of the top right, which is just a partial hip replacement. Okay? So if you're young and active and you break your hip, and if you break it just right, you can have a hip replacement to treat it too. Okay? So what is your defense? Because we see this is an epidemic. Okay? I'm on call, once a week, and pretty much every time I'm on call, a hip fracture comes in that needs surgery, almost every single time. And so it is an epidemic. It doesn't always occur in 90-year-old men and women who live in nursing homes and roll out of bed. Unfortunately, that's not true. Okay? I see 60-year-olds, 70-year-olds, 80-year-olds that trip on a curb and fall and break their hip. And a lot of times, people are never the same. And most of the time, their hip breaks because the bone quality is bad. Okay? So what do you do? How do you guard against it? Fix your bone health. Get your bones healthy and prevent osteoporosis. Okay? And let's see how we do that. Okay? So first, bone is a living tissue. Okay? It is constantly being repaired, mended, built, broken down. It's in constant flux. Sitting there right in your chairs, something's happening to your bone. Okay? Now there's two types of cells. There's the osteoclasts. They break down the cells, or break down the bone. Okay? So they dissolve the bone to make way for new bone, which is brought about by a different type of cell called an osteoblast. Okay? So these two competing cells, they are the balancing act of your bone health, of your bone density. Okay? And so the drugs that we treat osteoporosis with affect those two cells. Okay? So, in terms of normal growth and development, most of us achieve our peak bone mass by 20, the age of 20. That's when you're at your peak. Okay? We maintain it, though, usually pretty well until about 35 or 40 years of age. Okay? So, and I just turned 40. All right? So, I'm on the decline. Okay? After age 40, men and women begin losing bone mass. Okay? In the early days, it's pretty slow. You lose it 0.5%, 1% a year. So it's not real brisk. Okay, so I'm not going to be whittling away during our talk here. But women lose their bone at an accelerated rate after menopause, particularly the first 10 years after menopause, because of the protective effects of estrogen. Okay, so once you hit menopause, the bone loss ramps up. Okay, it accelerates to 2 to 5% per year. Okay, men lose the bone much more slowly than women do. They don't have the estrogen issue. Okay, but after the age of 65, their bone loss occurs faster as well. Okay, so men, you're in this boat too. So, what are the 4 things that contribute to bone health? And we're going to talk about these things. Nutrition, okay? That's one of the keys. Physical activity, probably the most important thing that I'm going to talk about. There's some genetics. We know, it's passed down from generation to generation, so some of this osteoporosis stuff is inherited. And there's also this hormone effect that we're going to talk just a little bit about, okay? And yes, there's a picture from my dancing competition. I did get a trophy, by the way. Did you hear that? A trophy for dancing. No, it's tucked in my office at home. So, all right, so there's a big messy slide. These are all the risk factors for osteoporosis. There's a whole bunch, okay? So first, biggest risk factor is being a woman, okay, and that's the estrogen effects, okay. Obviously, this is an important topic for us all in this room, okay. Being older, having hormone imbalances, after menopause, dietary things, not enough calcium, not enough vitamin D, low physical activity, being a very thin or petite Caucasian woman. So being white and very thin. That's a very significant risk factor. Smoking is a big one. Drinking too much alcohol or coffee or caffeine is also a risk factor. Okay? It interferes with your bone metabolism. All right? Drinking affects your nutritional makeup, so that's how that works. Family history, so again, an inherited thing. And certain medications like too much prednisone or different types of medications can negatively impact your bone density, certain diseases. Basically, the more risk factors that you have checked off on this list, the greater your risk is, and you ought to be tested if you haven't been. Okay? And Medicare pays for it every 2 years after the age of 50. So now, certain things that you can change. Well, at least not easily, like your gender. You can probably change that. Not easy, though. So that's something you're just blessed with that. Your age, unfortunately, that happens to us without anything that we can do about it. Your genetics, your inheritance, and your ethnicity. Those things, those are the cards you're dealt. Okay. But there are things that are very important that you can change to stop this and to improve your risk of getting osteoporosis. Changing your diet, nutritional choices, smoking cessation, having moderation in how much you drink, coffee or alcohol, and physical activity. Okay, these are lifestyle choices. We all have power over those choices in this room. Now, how do we diagnose it? How do we diagnose osteoporosis? That's with a bone density test. It's painless. We have one in our office. Most family practitioners in this community have bone density scanners. It's safe, it's painless. Again, Medicare pays for it. It's paid by most private insurances as well over the age of 50. It detects bone density, but it's just a snapshot of your bone density. And it's usually done in the hip and the spine. And it's a very low dose X-ray test. So it's not tons of radiation. So getting it every 2 years isn't going to make your hair turn red or glow in the dark or anything like that. So how's it diagnosed? Okay, a bone density test is basically, it's kind of like an IQ test. It's basically you're compared to your peers and to a section of the population that we consider the average young adult. Okay, so there's 2 scores you get when you get a bone density. You get your T-score, which is where your bone mass is compared to the average young adult. Okay, and that's the one we typically use. Okay, because if you're in between 20 and 35 years of age, that's when your bone density is at its peak. Okay, that's who we're comparing it to, so you know relatively how much bone you don't have. Okay, so that's the T-score, and then the Z-score is when you're compared to people of your same cohort and age. Okay, now what are the score ranges? So a normal score is between +1 and -1. It's kind of a weird scale. Okay, it's based on a standard deviation. It's a mathematical equation, but basically if you're 0, you're perfect. +1 means you got a little more bone than the average person, so that's not so bad. -1s mean you're one standard deviation or less below the average. Okay, so that we consider that a fairly normal range. That's where you want to be. Okay, and there's 2 gradations of having weak bones. There's osteopenia, okay, which means you're kind of on your way to osteoporosis. You're just not there yet, and that's a T-score between -1 and -2.5. And then there's frank osteoporosis, when your score is below -2.5. Okay, and then the risk of fractures go way, 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 way up. Okay, so that's the bone density test. How many in here have had their bone density tested? Okay, how many have had their bone density tested in the last 2 years? Good. How many are due for a bone density test? Yeah. All right. So if everyone takes a message home tonight, you got to do this. You got to know what this is, because it's critical not only to your healthy hips, but to your functional independence going forward if you're so unfortunate that you fall and break a hip.
How often should you get one?
Every 2 years. That's what insurance pays for. Okay? And men should do it too, especially if you have risk factors. Okay? And if you have enough risk factors, insurance will pay for men to get it done too. So now, what is the treatment? The treatment is prevention. And the treatment is prevention. And the treatment is prevention. Okay? You got to prevent hip fractures. You got to prevent getting osteoporosis. It is critical. Okay? There are medications to help you prevent it. There's drugs that you can take. And remember those 2 bone cells we talked about. Most of the drugs attack or affect the osteoclasts. They slow those cells that are responsible for breaking down the bone. Okay? And there's a whole bunch of them that y'all are familiar with. You've heard of Fosamax and Actonil and Aniva, and they affect the osteoclast. They slow down those cells that are responsible for breaking down the bone. All right? There's other things, you can take an estrogen supplement. That's not done very often anymore, pure estrogen, because there's also some negative consequences of being on estrogen, like it can affect your risk of getting breast or uterine cancer. But there's other types of estrogen, selective estrogen receptor modulators, that kind of do the same thing. They replace the estrogen in your body by targeting the receptor for estrogen, and they don't have the negative consequences of increasing cancer risk. Okay, so if you go through menopause prematurely or have some happen where you are without estrogen, there is a supplement you can take that does not elevate your risk of cancer, that can be protective to your bones. There's one type of drug that is shown in the top right picture. Unfortunately, it's an injection, so that's why it's not high on everybody's list of the drugs that they like to take. But it actually stimulates the osteoblasts, the cells that are responsible for building the bone. Okay? So it actually probably preferentially increases your bone mass quicker than those other drugs that just slow the degradation of your bone. All right? And it's called Forteo. It's not new. It's been around, but it hasn't caught on yet, because right now it's an injection. It's a once-a-day injection. It's like if you were a diabetic and you're on insulin. Okay, so it's a tiny needle. You give it to yourself right kind of in the little skin fold. It's just a subcutaneous injection. It's not really that painful, but it is an injection, and that's undesirable. So it hasn't gained widespread favor. But it's one of those building drugs as opposed to slowing the breakdown. So it has a lot of potential, especially if it's daily. The side effects are there aren't that many, actually. Injection site pain. If you've ever had there's a special type of cancer that if you have a family history of, you're not allowed to take this kind of drug. But it's not a common one. It's a rhabdomyosarcoma. So there's very few. There can be a little bone pain associated with it, but it's a fairly well-tolerated drug. In fact, it's better tolerated other than injection site pain. It's better tolerated than some of the other drugs, like how many people have been on Fosamax before? Okay, that has a lot of side effects. Okay, that's a hard pill to swallow. Sorry, yeah, that's okay. There's a lot of side effects with those other ones, and no drug's perfect. I mean, even Tylenol's not perfect. So But it's got some promise, and if you're at really high risk, it's something you all should look into, okay? We are in the process of developing an osteoporosis clinic right next door, okay? My partner and I, Dr. Krenzel and I, this is such a passionate topic for us because, you know, we're hip surgeons and knee surgeons, that we're going to start an osteoporosis clinic. Now, we're in the earliest phases. It probably won't be up and running for about 6 months, but we're very interested in this Forteo drug is one that we're going to try to really push. Not because I have any connection to it, because I really think it dramatically increases your bone density compared to some of these others, which really are just slowing the degradation. Okay. How do we prevent osteoporosis? We got to optimize our bone health by ensuring good nutrition. Okay. And of course, we all know we need to eat a diet high in calcium and vitamin D. So foods that have high amounts of calcium, dairy, milks and cheeses and yogurts, vegetables. Can't say I'm a big fan of collards, but I do like broccoli. Fish actually is very high in calcium, and so those are your foods that you could kind of preferentially eat. There are some foods that are harmful in terms of your calcium homeostasis that actually increase calcium loss, like caffeine, excessive salt. There's calcium supplements that you can take. There's kind of two forms of calcium that you can take. There's calcium carbonate and calcium citrate. And they're common in calcium supplements. Calcium carbonate's a little more constipating, but it's very inexpensive, as opposed to calcium citrate, which is less constipating and a little bit better absorbed, but it's, of course, a little more expensive. So what are your calcium requirements? Okay, I can think most of us in this room are in the bottom two. So that means 1,000 milligrams of calcium a day, or 1,000 to 1,500 milligrams of calcium a day. Okay, that's a whole bunch actually, and that's why people often have to supplement, because your normal diet doesn't get you this usually. Okay, you know, unless you're drinking a whole bunch of milk. Okay. Vitamin D is another important nutritional category. Calcium is not very efficiently absorbed without the help of vitamin D. And adults over the age of 50 need 800 units of vitamin D in their diet. Now, fortunately, you can get vitamin D from other sources other than your diet, like being in the sun. Okay? Sunlight can, 15 minutes a day in the summer, can improve your amount of vitamin D in your body. Okay? There's milk that's fortified with vitamin D. Fish, again, is eating fish it provides not only calcium but also vitamin D. And there's also vitamin supplements. Probably one of the keys, you know, we probably all do a fairly good job in this room. Your family doctors get you on the calcium supplements you need. They check your bone density pretty regular. They get you on the bone density medicine you need to be on. And you know, do pretty good with vitamin D. And this is the part that we probably all could do just a little bit better. And that's physical activity. It is probably the key. It really is. It's probably the #1 most important thing you can do to help yourself. Okay? Physical activity leads to healthier bones. It actually increases bone density. Okay? Better coordination and balance, improved muscle strength and flexibility, better endurance, improved posture. Physical activity is the key. So what kind of activity? Okay. Well, weight-bearing exercise is the most important. You need to load the bones to stimulate bone formation. Okay. I showed you a slide earlier that said if you're inactive, your bones tend to deteriorate a little bit. Well, this is the opposite of that. If you do weight-bearing activities and you load your bones, it shifts the continuum towards bone formation. So the blasts, those osteoblasts, win over the osteoclasts. Okay? If you're inactive, then it shifts the other direction. Then the osteoclasts win, and the osteoblasts lose, and the bone becomes more fragile, more brittle, and you lose bone mass. That's how weight-bearing exercise works. All right, and I talk almost every patient that comes into my office about we're talking about arthritis or their bones, about these exercises. Okay, walking. Okay, walking 20 minutes 3 times a week. Nice brisk walk, relatively flat ground. Best thing you can do, not only for your brain and your mental health, but also for your bone health, and your diabetes, and your blood pressure, okay, and your obesity. Jogging, probably not something that we would do, you know, the older you are, probably that's not the #1 thing. But again, weight-bearing exercise, that's the concept. Biking, one of my favorite things. Stationary bike, or you know, even just biking outdoors. You got to do it for exercise, though. It can't be just a little leisurely coast. Okay, it's got to be for exercise. You load your femur, you load your knee, you load your hip when you push yourself on a stationary bike. Okay, and elliptical is another one I like. Stair climbing, dancing, racket sports, and golf. A lot of us, you know, we retire, we pick up golf. It's great. Just don't use the cart. Okay, go walk. All right, just that 2-hour round of golf. You play 9 holes. You walk for 2 hours. You do that 3 days a week. That's unbelievable. Good physical activity for your bones. Other types of exercise, weightlifting. Obviously, it directly builds your muscles. And when you're working your muscles, it loads the bone. Okay. There's balance exercises. Okay. You know, you got to have good balance to prevent falls. All right. There's different exercises you can do to improve your balance. Okay. And there's posture exercises you can do so that you're not slouched. All right. It works on your back extensors, your abs, your shoulder retractors. If you do 5 minutes of balance training each day, doing some form of this, one of those 3 things, you can really improve your risk of falls. In fact, Medicare pays for that. You know, people who are at risk for falls, you can get a home health therapist to come out and just do balance training. Okay, it's even recognized by Medicare how important this is to preventing hip fractures and what can happen if you do fall. Okay. Now, physical activity. How often should you do it? I would say 2 to 3 times a week. Not just weight-bearing exercise, but also some kind of strength training, whether you just use little ankle weights and do some leg lifts, or you get some 5-pound dumbbells. You should do those things about 2 to 3 times a week. Okay? You can't do it every day. That's too much. And I have a lot of people who recover from their knee replacement or hip replacement, and they try to exercise every day. They're 6 months out and they're still exercising. They're a year out. They're still going after it every single day, pound, pound, pound. You know what? That just causes inflammation, soreness, and pain because you don't ever give your body a chance to recuperate. Okay? So you do need a day in between vigorous exercise. You just have to. Your body has to mend itself. Okay? So 2 to 3 days a week. How intense should you do it? Well, if you're lifting weights, it shouldn't be maxing out. It should be about 75 to 80% of your best effort. Okay? How long should you do it? About 30 minutes. 20 to 30 minutes. You know? And if you're doing weightlifting, I would do 3 sets of 8 or 10 reps. If you're doing some bicep curls or something, 3 sets is enough, and do about 8 or 10 reps at about 80% of your maximal effort. Okay? Now, but you got to be careful. Okay? If you do have osteoporosis, there's certain things you got to be a little careful. Okay? You don't want to overdo it on weak bones. So jogging is just out. You know, if you got an arthritic knee or you got osteoporosis, you know, jogging is not meant for you. In fact, it's probably stair climbing and just going up and down stairs, that's probably a little too hard. You want to do things more like a stationary bike or an elliptical, something that's lower impact. Okay? You want to avoid things like jumping or jogging, and you also want to avoid things where there's a high risk of falling. So if you have osteoporosis, you're probably not going to be the person who is out there biking with their biking shorts and their little Speedo and their cap and they're on the highway, and it's just too risky. I mean, you get squirrely with your tire and you fall over, that's when you're going to break your hip. Okay, you got to use common sense and you got to do things that are safe. Okay. All right, so that's me on my soapbox about osteoporosis. Is there any questions?